Hi everyone, welcome to my YouTube channel. Today I have come up with this video series on landmark trials in critical care medicine on the demand of my juniors. The advanced critical care trainees who are preparing for examinations will definitely benefit from this video. If you like this video, please share it with all your friends, all your colleagues, and also subscribe to this channel for such videos. Alright, so we have about 100 plus major trials which are important to remember. To make videos shorter and make you guys easy to remember, I have grouped the trials into various sections or subheads you can say in the critical care trials. And in this video, we will focus on our first section, which is the trials conducted in the fluid therapy and hemodynamic resuscitation. Okay. So in this section, in this fluid resuscitation, the first landmark trial was the Rivers trial, or otherwise known as EGDT trial. So EGDT means the early goal directed therapy. EGDT includes arterial and central venous catheterization with continuous SCVO2 monitoring. So SCVO2 monitoring or SCVO2 measurement was very fancy at that time. Goals of EGDT were to maintain the MAP greater than 65 mm of mercury, CVP of 8 to 12 mm of mercury, and SCVO2 more than 70%. This trial was published in NEJM in 2001, and this was a single center trial in Michigan. It was conducted in Michigan, US. It changed the way intensivists around the world prescribed the fluid and vasopressor in next 15 years after its publication. So it enjoyed 15 years. Okay, it was a very famous trial. So this trial was a game changer. In this trial, 263 patients with severe sepsis were randomized into EGDT group and a standard group prior to admission to ICU. So EGDT group was given the fluid according to early goal directed therapy protocol. And what Rivers found was very interesting, very encouraging. They proved that EGDT is associated with significantly reduced in hospital mortality from 46.5% to 30.5%. So there was about 42% relative risk reduction, or you can say a 16% absolute risk reduction of in-hospital mortality. So it was very huge. That's the reason EGDT became very famous, very standard recommendation by many medical and surgical societies around the world. There were many limitations of its trial, and the main limitation out of various was that it was a monocentric trial. It was performed in single hospital. Moreover, the EGDT was a bundle of interventions, and it is difficult to ascertain the benefit of each intervention separately. Another limitation was that the lead author, the Rivers, was a paid consultant for manufacturing of SCVO2 measuring central catheter and has registered early goal directed therapy as his trademarks, which raised many doubts. That is the reason to challenge the findings from EGDT trial. 3 major trials were performed after 14 years, okay, in different geographical locations. The process trial was the first one, which was performed in the emergency department in United States. Then there was a RISE trial, which was performed in Australia, New Zealand, Finland, Hong Kong, and Ireland. And lastly, PROMISE trial was conducted in United Kingdom in 2015. It was published in 2015. So all trials showed no difference in mortality. Important and noticeable thing was that all these 3 trials, the mortality was strikingly lower. Remember, in Rivers trial, the mortality was 44% in usual care group, but in these 3 trials, the mortality was less than 30%. In the process and RISE, it was about 19%, and in the PROMISE trial, the mortality was about 29% in usual care. The reasons for the lower mortality in patients recruited in process, RISE, and PROMISE trial were that the patients were less sicker in these trials, okay, compared to the patients recruited in the original Rivers trial. Another issue was that the fluid which was given in these trials in the usual care group was about 2 to 3 liters before randomization. So the protocolized fluid resuscitation became standard over these 14 years. So that is the reason we see a lower mortality in these trials. A meta-analysis was published in 2017 combining the data from Process, RISE and PROMISE trial. So this meta-analysis found that the mortality at 90 days was similar for EGDT and the usual care group, 24.9% versus 25.4%. After this meta-analysis, people stopped chasing central venous pressure or CVO2 or urine output. So these targets of resuscitation were invalid. Now we will discuss why aggressive fluid administration is hazardous, it's actually harmful. See, fluid overload may exacerbate organ failure and shock. You know that very well. Due to edema in the critical care organ beds such as heart, kidney, lung and gut, it can lead to a lot of issues. It can cause reflex vasodilation due to release of natriuretic peptides. So these are various problems with the rapid fluid administration, lot of fluid administration. Moreover, the fluid bolus which you give can flush cytokine-rich blood from shut down capillary beds and exacerbate shedding of endothelial glycocalyx, which was shown in a major trial called FEAST trial, which emerged after 10 years of EGDT trial in 2011. The FEAST trial was a multicentric RCT of rapid fluid resuscitation in African children with features of shock. Idea was to compare effectiveness of initial fluid resuscitation with either 0.9% or 5% albumin solution, and it was compared with a control arm which received no initial resuscitation fluid. So there were 3 arms, okay, so albumin, saline and no fluid resuscitation. Unfortunately, the trial was stopped early because an excess mortality was noted in both fluid bolus arms. So this study highlighted that the fluid boluses may cause more harm, more problem, more mortality. People were taking more interest in the restrictive fluid strategy. So after EGDT it was proven to be hazard. That's why there was growing interest for an alternative approach, and that uses less fluid administration and more vasopressor at the initiation of shock itself. So a restrictive fluid strategy in patients with septic shock was being thought of, and then they designed 2 trials. So in 2022, the first trial was a classic trial which was published and which randomized 1,500 patients with septic shock in ICU who had received at least 1 liter of IV fluid, and it was compared with the patients who received restricted fluid. Okay, so there were 2 groups, a group receiving restricted fluid with the group receiving the standard liberal intravenous fluid therapy, including which included a lot of fluid boluses. So they found that a restrictive fluid group received a median of 1,700 or 1,800 ml of fluid in ICU, while the standard fluid group received about 3,800 ml of fluid, about 1,800 fluid or 2 liter of fluid extra. At 90 days, the mortality rates were similar in both groups. This was a striking finding. 42.3% in the restrictive fluid group and 42.1% in the standard group. So there was no difference in the mortality. This was the Colloids trial which was conducted in 60 US centers, and they were grouped into restrictive and the liberal fluid management. As expected, the restrictive fluid group received less intravenous fluid but had earlier and more frequent use of vasopressors and for a longer duration than the liberal fluid group, and the mortality was similar in both groups, 14% in restrictive and 14.9%, you can say 15% in the liberal group. There was only hardly 1% difference, 1% difference in the mortality. So this was not significant. That is the reason. So this latest surviving sepsis guideline, which was published in 2021, this did not include these 2 trials. So still SSC downgraded the recommendation for the administration of large amount of fluid, that is 30 ml per kg, to a suggestion, and the recommendations are still weak. So I think we will have more clarity on the first fluid bolus during the septic shock. okay, in I think the next guideline in of surviving sepsis campaign. Now we will talk about the targets of resuscitation. When you are giving the fluid resuscitation, when you are giving a lot of fluids while resuscitating a patient, what are the targets of resuscitation? What are the endpoints of resuscitation? So the first target usually you chase is the mean arterial pressure, or you can say the capillary fill time, SCVO2, lactates. There are so many, and now they have the dynamic markers of fluid resuscitation also. So so now what is the evidence behind the measurement of SCVO2? Should we do it or not? See, the largest trials which were conducted in 2014, the ARISE, PROMISE and PROCESS trials, they have not used, I mean, they could not show any mortality difference using the SCVO2 based resuscitation. So and moreover, in 2010, Jones et al. Conducted one trial comparing the SCVO2 resuscitation strategy with lactate clearance resuscitation strategy. Okay, and they randomized 300 patients with severe sepsis or septic shock to one of two groups. One group targeting SCVO2 of more than 70% with the blood transfusion and dobutamine, and there was other group targeting the lactate clearance of 10% within the first 2 hours of resuscitation. So, so this Jones trial is very famous, and what they found was very interesting. Again, there was no significant difference in hospital mortality between the two groups. So they concluded that lactate clearance can be used instead of SCVO2, and later these PROMISE, PROCESS and ARISE trials also show that SCVO2 is of no use. So in current SSC guidelines, resuscitation targeting decreasing serum lactate in patients with elevated lactate level was suggested, and there is no point, I mean, there is no suggestion to use the SCVO2. Some people suggested to use even capillary refill time instead of lactate clearance. Okay, but in addition to other resuscitation markers. So measurement of capillary refill time is a widely used method to assess the peripheral perfusion at the bedside. You know that if it is prolonged more than 3 seconds, it is abnormal, and the fluid resuscitation may be guided by CRT monitoring, and there has been a very famous trial which you should know. So in this trial, CRT guided resuscitation was compared to a lactate clearance targeted strategy, and this trial is named as Andromeda shock trial, which compared these two strategies of resuscitation, and they found that the CRT guided group showed improved sequential organ failure scores at 72 hours, that is so far at 72 hours, and received significantly less resuscitation fluids within first 8 hours if they use CRT. However, there was no mortality benefit of using either targets. Okay, therefore SST guidelines suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion, other perfusion markers. All right, so you should know this important trial, Andromeda shock trial. Another target of resuscitation, as we were discussing, is the MAP, mean arterial pressure, where two famous trials have been done, sepsis PALM and 65. The sepsis PALM trial was conducted in septic shock patients who were given vasopressors randomized to two MAP targets. So there were two MAP targets, 65 to 70 millimeter of mercury versus target of 80 to 85 millimeter of mercury. This study found no difference in mortality between two targets of MAP, 34% versus 36%. Although a subgroup analysis demonstrated a 10.5% absolute reduction in the renal replacement therapy requirement with higher MAP targets among patients with chronic hypertension. So this was an important subgroup analysis finding. But targeting higher MAP with vasopressors may be associated with high risk of atrial fibrillation, which was shown in this trial. So a meta-analysis of two RCTs on this topic, this MAP target, concluded the fact that higher MAP targets did not result in improved survival or benefit of survival in septic shock patients. So this is important, that we can use the lower MAP. Other big trial on MAP target was 65 trial, which questioned the MAP targets of even 65. It said permissive targets of lesser than 65. It said permissive hypotension or MAP target 60 to 65 millimeter of mercury may be beneficial, and it will reduce the requirement of SOPSR. This trial was conducted in 65 ICUs in United Kingdom, published in JAMA in 2020, and there was no statistically significant difference in 90-day mortality when you are using lower MAP targets 60 to 65 millimeter of mercury. So the mortality was 41% versus 43.8% with absolute risk reduction of 2.85%, non-significant. Surviving sepsis guideline 2021 recommends targeting a MAP of 65 millimeter of mercury in the initial resuscitation of patients with septic shock. Now we will move on to the choice of fluid in the resuscitation, which is quite interesting part of resuscitation. There have been debates, there have been various trials. So we will enumerate those trials, we will discuss those trials. In 2004, SAFE study was the first study which randomized 7,000 ICU patients to 4% albumin versus 0.9% normal saline or saline group. Again, SAFE study showed no difference in all-cause mortality between the two groups. However, subgroup analysis of SAFE study in patients with traumatic brain injury demonstrated higher mortality with the albumin. Okay, so that is the reason we should not be using the 4% albumin in TBI patient. There was a second subgroup analysis in septic shock patient, and they found that there was this non-significant trend towards the mortality benefit with albumin use in the patients with severe sepsis. Now we will go to 2014 Albios study, which further investigated the role of albumin administration. So this Albios study was done in 100 ICUs, including 1,800 patients with severe sepsis. Patients were randomized to receive either 20% albumin plus crystalloid to target serum albumin concentration of more than 30 gram per liter, or crystalloid solution with no albumin replacement in other arm. What they found was very interesting. During the first 7 days, patients in the albumin group as compared with those in the crystalloid group had a significantly higher MAP and lower net fluid balance. However, it failed to show any mortality difference at 28 day and 90 day. So only outcome difference was in the secondary outcome. Okay, like net fluid balance and MAP. Therefore, 2021 SSC guidelines suggested using albumin in patients who received large volume of crystalloid over using crystalloid alone. This recommendation was weak with moderate quality of evidence. One more point is that there is limited data available for the cutoff of albumin for the administration of albumin as a part of resuscitation. So there is no cutoff. What about colloid? Other than albumin, like starches, various trials were conducted in like chest, 6S, etc. So the first trial was the chest trial, in which 6% hydroxyl starch was compared with 0.9% saline for the fluid resuscitation in 7,000 critically ill patients. It was a big trial, large trial, and there were striking results from the chest trial. There was no mortality difference. There was 21% increased risk of requirement of renal replacement therapy in starch group. Moreover, there were increased rate of hepatic failure, rash and pruritus with the use of starch. So starch actually caused a lot of harm. Similarly, in blinded RCT called 6S trial performed in 800 patients with severe sepsis, 6% HES was compared with ringer acetate for the fluid resuscitation. There was at 90 days the use of HES was associated with 8% absolute increase in the mortality, 51% versus 43%. There was 6% absolute increase in the renal replacement therapy, 22% versus 16%. So starches were actually harmful. That is proven by chest trial and 6S trial. 1 year later, in 2013, crystal trial was conducted in patients with 2,800 patients with hypovolemic shock in Belgium, North Africa and Canada, and the colloids were compared with the crystalloids. It was a non-blinded trial, and this trial actually reached to only 3000 patients, and they found there is no difference in the primary outcome, that is all cause mortality at 28 days in two groups. The major limitation of this trial that it was a unblinded trial, hence prone to bias. And second issue was the trial was prematurely stopped due to long recruitment period, therefore required sample size was not achieved, hence this trial is underpowered to draw any conclusion regarding the primary outcome difference. So SSC guidelines strongly recommended against the use of colloid like Hess or gelatin. Now we will see the trials which compared saline versus the balanced salt solution. What are the trials which compared which crystalloid is better? Because normal saline is an isotonic fluid containing high concentration of chloride ions, while balanced salt solution have a similar chloride concentration to that of plasma. So it is more more closely related, more close to plasma. High chloride concentration in saline can expose the patient to high risk of hyperchloremic metabolic acidosis and a reduction in the GFR, high chances of AKI, and also fluid overload. So all these are the problems with the normal saline, and that is why people wanted to be sure that they are using the correct crystalloid, and that is why they conducted two major trials, salted ED and SMART trial in 2018, and these two trials they were balanced salt solution over saline due to lower major adverse kidney event, that is MAKE at 30 days, and lower 30-day mortality with the balanced salt solution. So balanced salt solution was favored in these two trials. Contrary to this, there were four major trials: split, salt pilot, basics, and recently plus studies, which showed no significant difference in mortality or AKI incidences while using comparing this BSS over NS. Okay, so a few points about the plus study, which is the latest in the list of trials on BSS versus NS. This was a multicentric RCT conducted in about enrolling more than 5000 ICU patients requiring fluid resuscitation. It did not show any significant difference in the 90-day mortality and adverse renal outcomes. So that's all for today. I have enumerated major trials related to fluid administration in septic shock and in other types of hypovolemic shock, and kindly share this video with all your friends, and in next video we will focus on some other section and I'm going to make video on that. So that's all for today. Thank you so much for your attention. Jai Hind, Jai Bharat.